Instead of lifting your body, your muscles are controlling your descent. This is called eccentric muscle activity, where your quadriceps are lengthening while they contract, acting like a brake to control how quickly your knee bends as you lower yourself. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. A few weeks after his knee replacement, David stood at the top of his staircase looking down. Going up had started to feel manageable, but going down felt completely different. He held the railing tightly, unsure how much he could trust his new knee, and each step felt like a test of strength, balance, and confidence. That moment is common for people early in the healing process. By the end of this episode, you'll understand why going downstairs is usually harder than going up after knee replacement, what is happening in your body during that movement, and examples of approaches that may be used in rehabilitation settings to help build the strength and control needed over time. We will also discuss how readiness for stair practice is often assessed and why guidance from your physical therapist or surgeon is important before beginning. This information is provided for general educational purposes only and is not intended as medical advice or a substitute for individualized evaluation, diagnosis, or treatment by a qualified healthcare professional. Let's start with a simple observation. Going upstairs and going downstairs are not the same task. When you go upstairs, your muscles are working to lift your body against gravity. This is called concentric muscle activity, where your quadriceps, the muscles at the front of your thigh, contract to straighten your knee and help push you upward. Going downstairs is different. Instead of lifting your body, your muscles are controlling your descent. This is called eccentric muscle activity, where your quadriceps are lengthening while they contract, acting like a brake to control how quickly your knee bends as you lower yourself. That braking function is one of the main reasons going downstairs feels harder. After a knee replacement, quadriceps strength is often reduced. This can be related to the surgery itself, as well as swelling, pain, and a phenomenon called arthrogenic muscle inhibition, where the nervous system may temporarily limit how strong muscles can contract around the joint. Even if your knee feels stable when walking on flat ground, going downstairs requires a higher level of control. The quadriceps must absorb body weight, control knee bending, and help keep movement smooth and steady. If that control is not fully restored yet, you may notice compensatory strategies. You might lean more on the handrail, step down with your operated leg first, or turn your body slightly sideways. These are commonly observed strategies used to maintain safety. Progression is typically guided by a qualified healthcare professional to help ensure it is appropriate for your specific situation. Let's talk about the mechanics of going downstairs. When you step down, your leading foot reaches the lower step while your trailing leg remains on the higher step. As you shift your weight forwards, your knee bends and your quadriceps control that bending to prevent a rapid drop. This requires a combination of strength, balance, coordination, and confidence. Your knee also experiences higher forces during stair descent compared with walking on flat ground. Research has shown that joint forces can increase significantly during stair activities, meaning your muscles must be prepared to handle that added load. This is one of the reasons stair descent often requires more preparation and conditioning during your healing process. It doesn't mean stairs are inherently unsafe, but it does mean they demand more from your body. Balance is another important factor. When you go downstairs, your center of mass moves forward and downward, and your body must continuously adjust to maintain stability. If your balance feels uncertain, your brain may interpret that as a risk and respond by increasing muscle tension or limiting movement, which can make the movement feel stiff or awkward. Fear can also influence movement, even if your knee is physically capable. Concern about falling may change how you move. You may hesitate, move more slowly, or avoid fully loading your operated leg. This is a protective response, but it can also affect how the movement is performed over time. So now we have several overlapping factors: reduced quadriceps strength, decreased eccentric control, balance challenges, higher joint forces, and sometimes fear. Together, these help explain why going downstairs often lags behind other activities during rehab. Now, let's talk about how this may be addressed in rehab settings and how readiness for stair practice is often evaluated. Before getting into specific examples, keep in mind that these are general approaches commonly used during the healing process. And your situation is unique, and your surgeon or your physical therapist typically guide your specific plan. And it's especially important to confirm with your physical therapist or surgeon that stair practice is appropriate for you before attempting it independently. There are a few general signs clinicians may consider when evaluating readiness. They can include your ability to stand and walk on flat ground with good control, your ability to shift your weight onto your operated leg without significant pain or instability, and your ability to perform basic movements such as sitting to standing with reasonable control. Some individuals may also demonstrate a small step down or controlled lowering movement in a supervised setting before progressing to a full set of stairs. These are examples instead of requirements, and decisions are truly individualized. In many rehab programs, clinicians emphasize gradual progression over time. Early after surgery, many people use a step 2 pattern. When going up the stairs, stepping up with the non-operated leg first and then bringing the operated leg. And then when stepping down, lowering yourself with the non-operated leg by stepping first with your operated leg down. This reduces the demand on your replaced knee and often is used initially. It's common and appropriate for a starting point in many cases. As strength and control improve, some individuals may work toward a step over pattern, where each foot alternates naturally on each step, which is the normal walking pattern that we generally use when we don't have knee pain. This transition is typically guided and progresses at a pace that's appropriate for you. Before practicing full stair descent, clinicians often focus on building the necessary components. One of the most important components is quadriceps strength. In rehab settings, clinicians may use exercises such as sit to stand, mini squats, and little step-down variations to help develop the strength needed for stair descent. Performing graduated stepping up is a common progression, starting with a 2-inch, then progressing to a 4, 6, and 8-inch step. As performance improves is common. A physical therapist can demonstrate how to perform the step exercises safely. Another important component is eccentric control, which involves practicing movements where muscles control a lowering motion. Graduated stepping down can be progressed in a similar fashion to stepping up that we just talked about. Technique is important for stepping down, and having a therapist advise you on your movement quality is invaluable. Also, clinicians may incorporate controlled lowering into a chair over several seconds, which can resemble the demands of stair descent. Balance training is also commonly included. Exercises such as supported single leg standing, weight shifting, or controlled movements with assistance may be used to help improve your stability. And these are typically performed with appropriate support and supervision, especially early in the healing process. When you begin practicing on the stairs themselves, clinicians often recommend a safe setup. And this might include using a handrail, having additional support available, and choosing a staircase with good lighting and non-slip surfaces. Hopefully in the clinic you have good lighting and non-slip surfaces. A step 2 pattern may still be used initially with attention to placing your foot fully on the step and moving in a controlled manner. Progression is typically gradual. In clinical practice, variables such as the number of steps, the level of support, or movement pattern may be adjusted over time rather than changed all at once. And your response to the activity is also considered. You might experience mild soreness after a stepping activity because it's challenging for the knee. But what's appropriate can vary, and your therapist can help you interpret these responses, especially if symptoms such as persistent pain, swelling, or stiffness occur. And there are also situations where stair descent may remain more challenging. Significant quadriceps weakness, limited knee bend, balance impairments, or other joint issues can all affect your ability. In these cases, working with your therapist can help you guide a more individualized approach. Changes can continue over time, and you might notice that stairs remain difficult a few months after surgery, but strength, control, and confidence can continue to improve beyond the early healing period. Research on functional progress after knee replacement suggests that activities requiring higher levels of control, such as stair descent, what we're talking about, often take longer to return, and this reflects the complexity of the task. If stairs are an important part of your daily life, then discussing that with your healthcare team, if you're having trouble with it, can help guide rehab priorities. And for those who don't regularly encounter stairs, rehab goals may focus more on other functional activities first, function varies based on individual needs and environments, though the ability to climb stairs is related to higher function overall. If you want some more practical strategies and education geared to where you are in your process, check out the link in the show notes to join the Total Knee Success Insider newsletter. I break things down in simple, actionable ways to help you keep moving forward from where you are in the healing process. Also in the show notes, you'll find a helpful resource if walking still feels awkward or uneven after surgery. My book, Walking Like Yourself Again After Knee Replacement, goes deeper into why walking can feel frustrating, even weeks or months after surgery, and what factors can influence improvement. It's based on clinical experience and current evidence, and it's designed to help you better understand what you're feeling and how people rebuild smoother, more confident walking over time. Going down the stairs after knee replacement is often harder than going up because it requires controlled lowering, strong quadriceps function, balance, and coordination. These elements take time to rebuild. Readiness for stair practice is typically determined with guidance from your PT or surgeon. Approaches used in rehab often focus on safety, support, controlled movement, and gradual progression. Your experience may vary and progress can continue over time with appropriate guidance. In episode 95, we'll discuss how to get in and out of a low car more easily, why it can feel so awkward, and practical techniques to make the process safer and more comfortable. Thanks for joining me. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.